I also find it's really important to manage the patient's expectations. Particularly, if they've had an operation, for them to understand that there will be a degree of pain, but this isn't necessarily bad, and finding that balance with pain relief, especially to doctor in care of the elderly. And at this moment, I am posted in auto-generate reports. So I look after patients who had fractured neck of femur and has been operated, and we look after them following the operation until they go home. For me, pain is important, because if someone is in a lot of pain after the operation, their rehabilitation is delayed. And the least I can do for someone who has gone to the trauma of a fractured bone and surgery is to give them some pain relief and comfort. So it is very important. We review pain every day and we try to alleviate the symptoms as much as possible. For this, my main help comes from the physiotherapists, who always gives us feedback about whether someone is in pain or not. We also have to remember that for frail elderly patients who are in pain, if we give them too much painkillers, some of which a side effect of causing drowsiness and delirium, we might harm them rather than benefit or improve their rehabilitation. So it's a fine balance, which we always have to consider when we give any pain relief. I'm a physiotherapist or at Raymond Orthopedic Ward pays, for we all biggest barrier that we get with patients, and they're quite surprised when we go to them day one asking them to get out of bed. It's important that they understand that how important it is for them to move as soon as possible to ensure that they maintain muscle strength, length, joint, range of movement and their functional ability. If pain is a limiting factor, then patients generally become more static, and this then associates stiffness, and then that causes more pain. This then causes a vicious cycle, and that's really difficult for us to break. So, just listening to that, and I think we know this anyway, that there are so many opportunities during the day in different ways to recognize pain in older adults. Yeah? And it affects each member in a slightly different way, with what they're trying to do with patients and their interaction with patients. I think the biggest thing there is to actually make sure it's all brought together, that if you're recognizing it in one area, that you're telling someone else, so that the whole group can act on it. Exactly. And preempts any pain that they might have in the future. And so when we think about pain, we have to start with, well, what is pain? We all sort of intuitively, we instantly, we all intuitively know, it's when something hurts, but really what actually is it? Yeah, so I'll kick off with a sort of definition. So I think pain is an unpleasant sensory and emotional experience associated with an actual or potential tissue damage, and is described in terms of that damage. I think it's important to remember that pain is always a subjective experience. And I remember having my wisdom teeth taken out what I was doing psychiatry placement, and it really kind of got me attuned to personal experiences and what's real for different people. And the dentist said to me, that can't be painful. I've already given you the most painkiller there is, well, it is hurting to me, so it doesn't matter if you say I've had the right amount or it's in the right place, it hurts right now. Yeah, that's first time that kind of clicked into place for me. You can't say someone isn't in pain. No, exactly. It's very much. It's pain is your feeling. Yeah, and I think the other bit from that definition that I quite liked, and maybe I'd not forgotten but maybe not thought about for a while, is the fact that it is tissue damage in some form or another. If you've broken a bone, then clearly it's damaged. But it osteoarthritis is damaged. If you've got an infection or cellulitis or something, that's painful process issue. Damage is in this process, that's driving it. Yet is that definition that we gave comes from the International Association for the Study of Pain, and as ever we'll reference this in our show notes, so you can look at. It's actually they meet towards that kind of practical element of, is this kind of Chronic pain, or how is this pain arising from this person, is quite an important distinction to have about what's causing the pain and also the potential long-term effects of any medication that you might put that person on alongside their comorbidities. So really working out what it is and seeing if you can address that problem and get rid of the cause of that pain, in the first instance, is what you should do. So that's one of things we're going to talk about, and it's really underreported and probably untreated in older people, especially patients with cognitive impairment, and we sort of touched on that a little bit in the delirium episode when we talked about the fact that pain can cause delirium. But also pain relief can cause delirium, and really it's important to go looking for it. And I think the same sort of thing is true here with pain. It's important to go looking for pain, because if you don't ask, people may not tell you, or they'll say, oh well, you know, the pain's not too bad, but actually then when you speak to a therapist later on, when they try to stand them and walk them, the pain is it's a really limiting factor, and so you don't have to go looking. Yeah, thanks. And it does link back to one of the things we mentioned in that episode on delirium, where that study in residential settings, where they gave paracetamol to people that were agitated and found that it reduced the observation and reduced the need for antipsychotics. Yeah? So we're going to start at the very beginning. We're going to start with some real basics of physiology of pain here, how you sense it, where it comes from, on how you interpret it. So you can understand each stage of the pain process and therefore, why some of the interventions may work. So we need a concrete example. So let us imagine that you're at home and you're doing some DIY, and I always am. I still often. She often says, I've been doing something away. So you're hammering something into some of your IKEA furniture, and then you miss the nail and you hit your thumb. So that point, if your thumb, the nerve fibers, the itis in the skin are stimulated by this mechanical stimulus. They convert that into an electrical impulse that travels up the nerves. Now there are two types of nerve fibers, fast ones and slow and fast. Ones are slow, ones alpha ones and C ones. So first of all, there's the fast ones. They're super fast. They was all the way up to the spinal cord and trigger a reflex action. So, that's when you drop the hammer. Will you drop the nail and you move your hand out of the way, straight out the way? Yeah? Then you've got your slower fibers, which contain a bit more information. So instead of just stopping at the spinal cord, they go to the spinal cord, but then they'll travel up the spinal cord in the dorsal column to the thalamus in the brain, which is the area of the brain that interprets and starts to distribute. That pain information is received, and that can go to all different areas of the brain. As we said, this is about sensation. It's about the motor response that you need afterwards. It's about the emotional response at all of those things that happens in the brain, the thalamus. And it starts to ping it out to wherever it needs from. That explains why that throbbing pain that you then get takes, a couple more seconds to develop. Yeah, that's everything else. So I came up with what I think is quite a nice analogy. You can tell me if you disagree, and we've had quite a few paramedics listening. So we thought we'd do a bit of an emergency scenario analogy for the fast and slow fibers and the response. So we're going to say there's been a car crash and your first responder's maybe your St. John's ambulance. It's her passing by, or your fire brigade. They're there to clear the immediate danger. They're there to do a bit of basic life support to remove you from that immediate harm. Working to algorithm, no nonsense, just make the place safe. Fast fibers to the point. Okay? And that way. So the slow fibers are your paramedic crews that come along. They are your HEMS crews. They come along and they start doing your advanced life support. They start doing much more advanced things with the area and delivering treatment. Ring equipment and medications along. So that's what your C fibers. Do you get your response from your brain to increase your blood supply to activate platelets? You wanted this other kind of stuff, and that's not to say the slow. Yeah, the still super fast but just not quite as fast as the other, response. Yes. And then after that you then get tissue damage and you get cytokines. So chemicals that pull in responses and pulling other chemicals to do stuff and unchange the physiology in that little bit. The body to cause inflammation and swelling, and things like that. Those chemicals also stimulate the nerve endings to continue that pain response. Which is why, if you've banged your thumb, and it swells up, and it's sore, that's why it's still sore until the swelling and everything is gone away, but you can interfere with that a little bit kind. Yeah, so you've got this nerve signal that's going up to the brain, and you can interfere with a little bit, because if you, for example, rub the area, as soon as you bang it, you'll see simulating those fast 3:48 p.m. so you, stimulating the fast fibers, and what can happen is that sort of blocks some of the slow fiber signals getting up there, and so it can take away some of the pain. If you want to read a bit more, that's called gate theory, and then you've got endogenous opioids as well. Haven't used it already? Snake, exercise. That's one of the theories that exercise and physiotherapy endings can help with some elements of pain, and then you've then got the signals then that come back down from the brain. And there are mixture of nerves that use serotonin at the nerve transmitters and noradrenaline, and you can sometimes use some of the antidepressant medications such as SRIs. I'm at research. Cyclic tricyclics, yeah, to interfere with that response to adapt some of the longer-term responses to the pain. So there's lots of different ways of managing pain, and we're going to talk through some of the pharmacological measures now, but it's important to remember that there are non-pharmacological measures. But reason we wanted to talk about this was that in one of our faculty meetings, we were talking with the people in one of the things that came out of it is often when people come back off rotation, their whys, the wherefores, the hows of some of the pain relief or something that people didn't really get. So we thought we'd, hopefully, try and address that a little bit. We were worried this would be a bit to Medicare or a bit to pharmacy, but actually I think it's something that a basic understanding of these things is really useful for everyone. So we're going to focus on the cause of the pain, and then the drug therapy to treat it. So a few different types of pain. Let's go through them. Yeah? So we've got pain caused by inflammation, such like rheumatoid arthritis, in a joint. When it's all inflamed, we've got direct injury to a nerve or nerve endings. Like when you have surgical damage or when you've got a disc prolapse, pressing on a nerve, we've got pain when there is peripheral neuropathy. So where the nerve has died or become damaged for a reason. Then we've got pain that could be due to an underlying problem within the spinal cord or up in the brain where you feel that there's pain, even though there's no obvious stimulus to it. So if you have some people that have had a stroke in the thalamus and they can feel like this ongoing, intractable pain, but actually there's no stimulus to cause it, which links back I think to what we were saying earlier about it being a subjective thing. It's your feeling then moving on from that. There's a very similar thing where you have an abnormal activity in the nerve circuits, you perceive as pain. So for example, phantom limb pain. Yeah, and also the psychological aspects of pain. So as we said, it's linked into emotional responses that we have, and that can make it very difficult to treat when they become a significant contributor to things, which they often do in chronic pain. And that's something that palliative care. And they're very good at treating pain for lots of different reasons, but one is that they paid particular attention to this area. It's some type of something we often miss in hospital. Yeah? Definitely. So they're the 6 main causes of pain, I think, as far as we're concerned. But if you think there are others, please do let us know. And we now just going to talk through some basic painkillers, really? Yeah, and talk through how they work, what they do and what they might be useful for, and some common kind of troubleshooting things for each type of pain relief. So we're going to work up the World Health Organization ladder, which many of you will have heard of. And lots of you will have seen. Again, there will be a link in the show notes. It's a stepwise approach to starting some basic painkillers and then moving up the ladder each time. So, what's first is good old rusty, parasitical good. It's safe. There are very few contraindications to use of paracetamol, or really apart from full-on liver failure, in which case, you should check with the doctor. But generally, even in my liver failure, you can use Small relatively safely. It's one dose other than people who are very thin. So if you're less than 50 kilos, 1 paracetamol, otherwise it's 2, which is 1 gram. 4 times a day. Yes, that's 4 times a day. That's the only bind with it really, and how it works. It's quite a nice sort of foundation. It's a good baseline level painkiller. It's on average a little bit weaker than a non-steroidal anti-inflammatory drug that we'll talk about in a minute, but it's often better